The following podcast is part of a certified educational activity titled Finding Treatment Synergy in CLL, Expert Consults on Advances with Targeted and Cellular Therapy. Access the entire activity and complete the post-test at peerview.com/AEQ860. Downloadable slides and practice aids are also available.
Good morning and welcome to the session on CLL, Finding Treatment Synergy in CLL. My name is Maziar Shadman. I'm from Fred Hutchinson Cancer Center in Seattle. And I'm joined today by my colleague, Dr. Peter Rydell from University of Chicago. Looking at the CLL treatment landscape and the changes that we have witnessed in the past few years, we have moved completely from chemoimmunotherapy regimens in the frontline setting and in the relapse setting to using novel targeted drugs. We now have multiple clinical trials in the first line and also in the relapse setting that have shown that targeted drugs, including BTK inhibitors and venetoclax-based therapies, are superior to chemoimmunotherapies for different important clinical outcomes, mainly progression-free survival. So if you put these drugs in different categories, of course, Bruton tyrosine kinase inhibitors are one of the most important classes, with Ibrutinib being the first drug in this class. And as I mentioned, in multiple clinical trials in different settings, this drug, as monotherapy or in combination with a CD20 antibody rituximab, has been shown to be superior to our commonly used chemoimmunotherapy regimens. And then we started having access to next-generation BTK inhibitors, what we call second-generation. Acalabrutinib and Zanubrutinib have the same mechanism of action like Ibrutinib, but more selective for BTK, and for this reason, they usually come with a better safety profile. And all these three drugs are approved by the FDA for treatment of CLL in basically all lines of therapy. Pirtobrutinib is a non-covalent BTK inhibitor, or as we may call it, a third-generation BTK inhibitor. The drug is currently not approved for CLL, and we recently saw the approval coming for the mantle cell lymphoma. Of course, the approval for CLL may happen in future or near future, and there are also ongoing studies in the CLL area, including randomized studies. Venetoclax is currently the only drug from the BCL2 inhibitor class, and the drug is also approved for CLL treatment as monotherapy or in combination with anti-CD20 antibodies, either obinutuzumab in the frontline setting or rituximab in the relapse setting. And PI3 kinase inhibitors are still available as an option for patients with relapsed CLL. Both idelalisib and duvelisib are currently available for use. We know about the toxicity profile and concerns about infections and range of autoimmune conditions that come with PI3 kinase inhibitors. The studies that led to the approval of these two drugs were done in patients who were not exposed to BTK inhibitors or venetoclax. And for that reason, and despite the fact that we consider the third-line therapy, there's minimal or no data to show their efficacy in the setting that is most relevant these days, which are patients who receive BTK inhibitors and venetoclax. We should also note that despite all the advancements and the literature that we have been exposed to in the past decade, there is a wide gap between what we know and what is being done in practice. And we see that in a daily basis in a clinic, but the two studies that are shown here basically showed that in practice and in the community setting especially, and I would say even in the academic setting sometimes, we don't have all the information that we need to have before starting treatment and before making a decision about starting treatment. For example, the Inform CLL registry, which included almost 1,500 patients, showed that 1/3 of patients with deletion 17p or a mutated p53 gene did not receive what is recommended by the NCCN guidelines, and basically they did not get the appropriate therapy for their disease. As we will discuss, the treatment decisions for this patient population has to be specifically considered. Another real-world study of the US treatment patterns in CLL with more than 5,200 patients showed that, again, despite all the clinical trials that have shown superiority of novel agents over chemotherapy, almost half of the patients receive either chemotherapy, chemoimmunotherapy, or just a monoclonal CD20 antibody for treatment of CLL. So there's absolutely room and a need for more education and getting the knowledge closer to what happens in practice. So during this session, we will plan to look at some of the data and recommendations regarding specifically focused on high-risk CLL defined by having abnormality in the p53 gene, and also talk about targeted drugs and cellular therapy, specifically CAR T therapy for CLL. So we start with the case, and our case is a gentleman who is 72, and they present with symptomatic CLL, and they have not previously received treatment. So somebody who meets the indication for treatment. As we know, even now, even with all the novel drugs that we have, we don't necessarily offer treatment at the time of diagnosis, regardless of the cytogenetic risk. So the patients do need to meet the criteria for treatment, and this patient does. And deciding about the treatment strategy, there are patient factors, there are disease factors, and sometimes there are social factors that we consider. For example, in this patient, an important comorbidity is hypertension. Patient otherwise has a good performance status. The molecular information are critical to make clinical decision. This patient has a confirmed deletion in the 17p area. That's the location of the gene p53. And also the mutational status for IGHV is important to know. And for this patient has an unmutated IGHV gene. So high-risk features from the cytogenetic standpoint and a comorbidity that is hypertension. So going back to one of the questions that we asked, the two main classes for CLL are BTK inhibitors and BCL2 inhibitor. Venetoclax is the only drug in this category for now. And in the absence of any head-to-head clinical trial that has shown superiority of either approach, we basically have discussions in the clinic and consider many factors to come up with a decision. In patients with del17p abnormality, I would just make it more general, and with aberrant p53 gene, either deleted or mutated. We don't have a head-to-head trial, but we do have evidence from a number of studies that give us a really good understanding of the median progression-free survival on ibrutinib, on zanubrutinib, and acalabrutinib. And we also have data with venetoclax-based therapy. And in the upcoming slides, we will review some of the data. But in general, it seems that continuous therapy with BTK inhibitor provides a PFS curve that looks, by eye, superior to what we see with venetoclax-based therapy. And I should add that another factor that's listed here and is also important, and in my opinion, it's becoming even more important with this recent data that we're observing, is the mutational status of IGHV. In the study that was done with venetoclax and obinutuzumab in frontline setting, the German CLL14 study, there's a clear separation of the curves when you look at the mutational status of IGHV. It wasn't clear if that's because of the high correlation of that finding with del17p. So at the EHA meeting last year, when they controlled for everything, sounded like the IGHV mutational status was not independently predictive of the outcome. But at ASH, we had some data from another German group study, CLL13, and in patients without del17p, and it seemed that one of the independent predictors of outcome was the unmutated status of IGHV. So I know that some CLL experts have started using that information in deciding their treatment and going with BTK inhibitors versus venetoclax-based therapy. But that's something that is less established as del17p as a decision factor. And then the question is, okay, if we agree that BTK inhibitors are the best choice, we have many of them. We have 3 actually FDA approved as of now. And how do we select between ibrutinib, acalabrutinib, and zanubrutinib, or to make it more practical, between first and second generation, so ibrutinib versus the 2 second generations? So kind of very quickly looking at what's in the NCCN guidelines in terms of the treatment options or preferred recommendations for, first on the top, you have recommendations for patients without an abnormal p53 gene, meaning that they have a functional p53 gene. So these are, the options include acalabrutinib with or without obinutuzumab. We will show that this is based on the Elevate-TN study, treatment naive, which was a 3-arm study comparing acalabrutinib with acalabrutinib and obinutuzumab and the control arm was chlorambucil and obinutuzumab. And based on that study, we have a category 1 recommendation for acalabrutinib with the option of giving obinutuzumab. We also have venetoclax and obinutuzumab. That's based on the CLL14 study that I briefly mentioned. And then zanubrutinib, more recently, based on the SEQUOIA data, is approved and has received a category 1 recommendation. The other recommended options and kind of limited to the BTKI-based regimens for this talk is ibrutinib, and the reason why it's not one of the preferred regimens is, as we will show, is based on the safety data that, in 2 head-to-head trials, we know that the 2 drugs, acalabrutinib and zanu, are better tolerated with a better safety profile. You don't see any chemoimmunotherapy options, even in patients who have a functional and normal p53 gene. And moving to the next box, and we're focusing now on patients with del17p or p53 mutation, and it's pretty much the same as the prior box. We don't see the category 1s, mainly because there's no randomized study specific to those to that subgroup. But acalabrutinib with or without obinutuzumab, zanubrutinib monotherapy, or for fixed duration therapy, venetoclax in combination with obinutuzumab are your options, and then ibrutinib is one of the other recommended treatment options. Kind of quickly looking at the long-term follow-up from some of the randomized studies in this setting. The Alliance study was a head-to-head, 3-arm actually study comparing ibrutinib in one arm to ibrutinib and rituximab, and the third arm was the control arm of bendamustine rituximab. This was the study that did include some del17p patients, and the longest follow-up we have shows a 48-month PFS of 76% versus what you see with bendamustine rituximab, which is 47%. And this study established that ibrutinib-based therapy is superior to bendamustine rituximab. It also showed that there's no benefit of adding rituximab to ibrutinib. The second study is the Elevate-TN study, which I briefly mentioned. Again, a 3-arm study, acalabrutinib monotherapy, second arm, acalabrutinib and obinutuzumab, and then chlorambucil and obinutuzumab for the control arm. The 60-month PFS for acalabrutinib in combination with obinutuzumab was that 60-month PFS for monotherapy with acalabrutinib was 72%, and for combination of acalabrutinib and obinutuzumab was 84%, which both arms were superior to chlorambucil and obinutuzumab. So I should mention that when you look at the data, there seems to be some separation in the PFS curves when you look at the acalabrutinib plus obinutuzumab versus acalabrutinib monotherapy, which created some confusion because with ibrutinib, we decided that adding rituximab does not help, and this study showed that maybe obinutuzumab helps a little bit. I should say that because our focus is 17p deleted population, actually the subgroup that we did not see any improvement in PFS, even by addition of obinutuzumab, is actually the del17p population. So I don't think many of us are using acalabrutinib and obinutuzumab as the standard or our kind of to-go regimen, but in selected patients, adding an anti-CD20 antibody is necessary, and we use this data for that purpose. Then the SEQUOIA data was a randomized study comparing zanubrutinib to bendamustine and rituximab, and these are patients who did not have del17p, and you have a 24-month PFS of 86% with zanubrutinib compared to 70% with bendamustine and rituximab, and this was the study that led to the approval of zanubrutinib in the first-line setting. Now let's look at a specific population with an abnormal p53 gene, either deletion or mutation. With ibrutinib, this is a study by Dr. John Allen and colleagues, and they looked at the pooled analysis from 4 clinical trials, and they specifically looked at patients with del17p or p53 mutation. And as you see here, the median PFS is not reached, and the PFS at 4 years was 79%, with an overall survival of 88%, which is really impressive knowing that in the pre-novel agent era and when we had chemoimmunotherapy, the median PFS with the best chemotherapy combination that we had, which was FCR, was less than a year. And here we have such a great PFS and OS with BTK inhibitors. As I mentioned, the subgroup of patients on Elevate-TN study also had abnormal p53 gene, and here it may be a little bit difficult to, actually it's not. So looking at patients with del17p, the median, the PFS is in favor of acalabrutinib-containing regimens, and the median PFS is not reached in any of the acalabrutinib-containing arms. So again, another evidence that BTK inhibitors in the frontline setting are effective, and we will put these curves next to what we have from venetoclax in the upcoming slide. And this is from the SEQUOIA study, the cohort 2 of the SEQUOIA study. Remember, SEQUOIA study was, the cohort 1 was the randomized part of zanubrutinib versus bendamustine and rituximab. But in SEQUOIA, if patients had del17p, they would get zanubrutinib as monotherapy, and this is what's published from that cohort with median PFS of the 2-year PFS of 89%. So shorter follow-up with zanubrutinib compared to ibrutinib and acalabrutinib, but in general, this study, for example, enrolled more than 100 patients for just the del17p cohort. And overall, I think it's clear that BTK inhibitors are extremely effective in patients with del17p abnormality. Now, so on the left, you see the ibrutinib curve from Dr. Allen's study that I mentioned, and on the right side, the Kaplan-Meier curves from the CLL14. And if you pay attention to the arrow, these are patients who received venetoclax and obinutuzumab and had an abnormal p53 gene. Again, the practice of comparing studies, kind of different studies on one slide may not be the best practice, but I think you don't need to be a statistician to see that there is a median for that curve with venetoclax curve, and definitely the relapses continue to happen. And this is one of the reasons that some, and you know, for I would say many CLL physicians and investigators, BTK inhibitors are preferred choice for patients with abnormal p53 gene in the first-line setting. Now, I would just add that there may be patients, you know, there may be access issues or inability to take BTK inhibitors because of some absolute contraindications, which is not very common. It's not wrong to use venetoclax and obinutuzumab, and as you saw, it was listed on the NCCN guidelines. But then there should be discussions about the decision about continuing therapy at the end of defined 1 year and whether or not using MRD in that setting to make a decision. But that would be a topic that we can discuss if there is interest during the Q&A. How about combination therapy? The field is moving towards adding our 2 effective classes, combining them together. They have different mechanisms of action. You know, with BTK inhibitors, you block the proliferation. With venetoclax, you induce apoptosis, and it makes a lot of sense to combine them for many reasons. And, you know, what if we can achieve a complete response with undetectable MRD, and, you know, maybe those remissions are lasting for a long time, and maybe at some point we can claim a functional cure. So you see every year at the ASH meeting and other meetings, there are different follow-up results from many combination studies. So this is one example. Captivate is a study that looked at the combination of ibrutinib and venetoclax, and had 2 different cohorts, a fixed duration cohort, which is shown here, and there was a MRD cohort. And in fixed duration, everybody stopped treatment at the end of the defined period of combination therapy. In the MRD cohort, at the end, based on their MRD status, patients were randomized. But I mean, really the point is that when you combine these drugs together, you see effectiveness and very high rates of complete response, and also undetectable MRD rate at the bone marrow level or in the peripheral blood. And more importantly, if you look at the right side, and the gray area indicates the time on active treatment, and the rest of it would be the off treatment. And you see those curves are holding very you see that, you know, the follow-up is not very long, but relapses are rare. And, you know, an indication that a fixed duration therapy that's all oral and does not include any infusion, even a monoclonal antibody, could be effective and used in selected patients. based on the GLOW study, which was another study comparing the combination with obinutuzumab and chlorambucil, the combination is now approved in Europe for CLL. We don't have the approval in the US, but as I said, the field is moving towards combination therapy. It's not clear if you need 3 drugs. Do we really need to have a monoclonal antibody added to BTK inhibitor and venetoclax? We don't know that, but this is another example from the Dana-Farber group with the AVO regimen. This is acalabrutinib in combination with venetoclax and obinutuzumab. At the most recent meeting, American Society of Hematology meeting, they presented their updated results. The initial study that they did, and they included patients with all cytogenetic risk factors, but they expanded the study later to include more patients who had del17p abnormality or the p53 mutation. And so the initial 37 patients, I think, and then they added 31 more patients. And you see here they presented the 68 patient data. And really the point being that these are high-risk patients. 60% had an aberrant p53 gene, and you see a quarter of patients had complex karyotype, and also 75% had unmutated IGHV. So this is as risky as you can get in terms of the cytogenetic factors. And the treatment regimen is one of the challenges of looking at these combination studies is they're very different in their design and the time points of looking at MRD and decisions based on MRD. But in general, since we're talking about this study, the patients started with acalabrutinib, and after 1 cycle, they received obinutuzumab for a total of 6 cycles, and venetoclax was added at the beginning of cycle 4. After 15 cycles, they looked at the MRD. Patients who were MRD negative could stop treatment. MRD positive patients would continue for 9 additional cycles, and after 9, again, MRD negative patients could stop. MRD positives could continue or did continue. But really the point here is that if you pay attention, for example, to response by IWCLL, the blue bars, the second one is focusing on p53 abnormal patient and a CR rate of 52%. And again, other than CR, the PRs, it's very close to the 100%. Also, the MRD status in peripheral blood and in the bone marrow is shown, are both shown, and the p53 patients in the peripheral blood, there is an MRD negativity rate of close to 80% and 60% in the marrow. So extremely effective and complete remissions with undetectable MRD. This is a single-arm study. It's always important to compare our basically proposed experimental treatment with what's established. So the German CLL study group is starting, or I think it will start it. I don't believe it started to enroll, but looking specifically at patients with del17p or p53 abnormality, and they're planning for this randomized trial looking at AVO versus obinutuzumab and venetoclax. And I think this will be a very important study for this specific subgroup. So looking at triplet versus the ven obinutuzumab, which is already established for frontline CLL. And there are other studies that are looking at the AV and AV combination. In the US, we have the MAGIC trial, which compares acalabrutinib and venetoclax versus venetoclax and obinutuzumab. And there's AMPLIFY, which is a registration study looking at AV versus AVO versus chemoimmunotherapy. So we will get a lot of information in the near future about that combination. Zanubrutinib is our other next generation, second generation BTK inhibitor. And here we see that the SEQUOIA study had a combination cohort of zanubrutinib plus venetoclax. And the prior ASH meeting, we had some results from that cohort. And again, effective and high response rate and undetectable MRD rate. Now, where is the future of zanubrutinib in combination of BCL2 inhibitor is a little bit unclear, because there may be other BCL2 inhibitors that they may be interested in combining zanubrutinib with. But in general, the principle is that BTK inhibitors and BCL2 inhibitors could be combined, and they're very effective. So we talked about the selectivity of acala and zanu for BTK, and by not impacting other kinases, we expect a better safety profile, and that has been shown initially in intolerant studies, 2 studies with acalabrutinib showed that you could safely use acalabrutinib in patients who had side effects from ibrutinib. We have similar data from zanubrutinib that patients who were intolerant to ibrutinib could take zanubrutinib, and most of the patients did not have recurrence of their adverse events. And but in head-to-head trials, we also saw that in a more clear way. Elevate-RR was a study in the relapse setting that compared ibrutinib to acalabrutinib. In this study, only patients with del17p and 11q deletion were enrolled, and the primary endpoint of the study was non-inferiority of progression-free survival, which was reached. So acalabrutinib is not inferior to ibrutinib for efficacy, but more importantly, for adverse events, you see that there is a difference in terms of atrial fibrillation rate, for example, 9.4 versus 16% in favor of acalabrutinib. And in general, if you look at the time to onset and discontinuation rate, and even in patients with a prior history of AFib and aflutter, which are high-risk subgroup for cardiac complications from BTK inhibitors, you see that the rate is significantly lower with acalabrutinib compared to ibrutinib. So you have the cumulative incidence curves for atrial fibrillation on the left, and more importantly, hypertension is also less. The incidence is lower with acalabrutinib. Hypertension is one of the important adverse events from the BTK inhibitors as a class, and one of those side effects that, unlike others, can increase in rate over time. So there is more focus recently on hypertension as an adverse event, and here you see that the incidence of hypertension is lower. As we look at the Alpine trial in a second, this difference was not observed when zanubrutinib was compared to ibrutinib. And this is the Alpine study. Alpine study is also at the head-to-head trial of zanubrutinib versus ibrutinib in the relapse setting. The difference is that the study included all comers, so it was not limited to 11q or del17p. And there was a significant improvement in, the rate of atrial fibrillation and aflutter was lower in zanubrutinib-treated patients compared to ibrutinib, and 5.2% for zanubrutinib versus 13.3% for ibrutinib. As I mentioned, the hypertension rate was not different, and Alpine also showed superiority of PFS in all comers and also del17p. But here, again, the focus on cardiovascular endpoints are shown here, and again, lower rate of AFib and aflutter we saw, but that's related to cardiac events, and serious adverse events related to cardiac issues were significantly lower with zanubrutinib compared to ibrutinib. So we have great drugs, and many of them, but in fact, we really have 2 classes. What happens after patients are exposed to both BTK inhibitors, the covalent BTK inhibitors, and venetoclax? And what if those drugs fail the patient? And failure could be defined by having progressive disease or having adverse events that are not after adjustments and switching to a second-generation BTK inhibitors. I would say these days it's a rare case that you have a patient that you can't treat them with the second-generation BTK inhibitors. But in general, let's say that you have a patient who doesn't have the BCL2 inhibitor and a covalent BTKI as an option. The outcome is poor in those patients, unfortunately, even now. As I mentioned, PI3 kinase inhibitors are there, but they're really not studied in this setting, and their side effect profile is extremely concerning. As we know, in follicular lymphoma, these drugs were all pulled off the market because of safety concerns and lack of head-to-head trials. In CLL, we still have them, but not a reliable class in the post-BTKI and post-venetoclax setting. And we need to generate better quality data on what exactly is the benchmark in this setting. But this is one example based on the electronic medical records that shows you that if you have patients like that, and when you use the medical records, you have to kind of come up with definitions of failure. But basically, the time to next drug failure or death, if you look at the median, is in the range of less than 6 months. So absolutely an unmet need. And we have options still from the targeted drugs, and Dr. Rydell will talk about cell therapy as another important option. But very, very quickly, pirtobrutinib is our non-covalent BTK inhibitor and has been a drug that has shown efficacy in this setting. Here you see patients who basically, these are highly selected patients for being high risk. I mean, these are all BTKI exposed and BTKI failed, and we see that the overall response rate of 82%. CR rates in the not high, but that's what we expect from BTK inhibitors. So this is really an important class or important drug that hopefully we'll have for CLL. It's currently not approved for CLL. And also for Richter's transformation, just one slide. I mean, Richter's transformation is a true unmet need, and in this study, they reported a response rate of around 50% with a CR rate of 13% in patients with Richter's transformation. So pirtobrutinib will be an important drug for us for CLL when approved, at least in the setting of post-covalent BTK inhibitor and venetoclax. And in general, and I end by just kind of summarizing that BTK inhibitor and venetoclax are, of course, effective treatment strategies for us. With del-17p abnormal and p53 mutated, it seems to be an agreement that BTK inhibitor therapy continuously is preferred over venetoclax-based fixed duration therapy. Combination seems to be the future. There are many studies, and at some point we'll decide what combination and with what endpoint will be the standard. But there are many studies ongoing to kind of investigate that. And there's an unmet need for double failure setting, patients who are post-BTK inhibitor and post-venetoclax, and we really need to come up with treatment strategies for these patients. With that, I think I will have Dr. Rydell continue on cell therapy.
All right, good morning. So we'll jump into the cell therapy section here. So I'll also start with a case. So in this case, Heather is a 68-year-old patient, recently diagnosed with symptomatic CLL. In terms of her risk profile, she's found to have an unmutated IGHV, along with a 17p deletion. And so, as for maybe a typical treatment paradigm, she's initially started on acalabrutinib as first-line therapy. With that, she does respond and enjoys, interval of approximately 4 years on therapy. In the second-line setting, after having progressive disease, she's then moved on into treatment with venetoclax-based regimen. This is likely based on the Murano data, which is 6 months of rituximab and 2 years of venetoclax. After the 2 years of venetoclax, unfortunately, though, she has progression about 15 months after concluding therapy. Next, she's moved on into our other FDA-approved class of agents, including PI3 kinase inhibitors. But as mentioned, response rates leave something to be desired in this class, and along with the side effect profile, it may not be the preferred treatment for every patient. At this point in time, she still has a preserved performance status. And so this brings up a number of questions. The first being is this patient classified as double refractory? And I'll get into really what that definition means in the upcoming slides. But considering that, what are the options for this patient at this point in time, having now failed a BTK inhibitor, having failed a BCL2 inhibitor, and not responding to a PI3 kinase inhibitor? We are, in the upcoming slides, going to show some data regarding the efficacy and to support the utilization of CAR T-cell therapy. Additionally, there is data as well to support the utilization of hematopoietic stem cell transplant, of course, our original cellular therapy. And then what about the use of venetoclax retreatment? And so, in this setting, as mentioned, there's very few options in those patients that have failed our typical treatment paradigm. And considering these other treatments such as CAR T-cell therapy, and then Dr. Shudman had mentioned pirtobrutinib as a non-covalent BTKI, if and when that becomes available, would be options. We'll go through some of the data in terms of hematopoietic stem cell transplants, although the field is really moving away from the use of that treatment just based on the efficacy and encouraging safety profile of some of our more targeted therapies. And then lastly, when we think about utilizing venetoclax again in a patient that has previously seen venetoclax, really at this point, the data is very unclear. And some of that is related to how we determine and establish that patients have been a venetoclax failure. At what point in time after concluding venetoclax and having relapsed disease do we think it's reasonable to re-challenge or not re-challenge that patient? And that's an area where we still need some more data. I think this also brings up some other questions in terms of if we're thinking about moving such a patient into an advanced cellular therapy option like CAR T, how does that actually happen? And at what point in time would it be maybe appropriate for a clinician to refer a patient for a CAR T cell consult? And much like with CAR T cell therapy in ALL or CAR T cell therapy in large cell lymphoma, sort of operationalizing CAR T cell therapy in these patients can take some time. Obviously, there's the initial consultation, there's the insurance approval, there's getting the apheresis slot, and so forth. And so all of those different pieces of the puzzle do take time to orchestrate. And especially in patients with high-risk disease, the disease isn't always waiting for us to accomplish all those different steps. And so this really brings up the point of referring patients that are high risk at the time of failure of first-line treatment would be a strong consideration. And that would allow, of course, the patient to have some familiarity with what CAR T cell therapy is, to meet the clinician, to understand this treatment approach a little bit better, which of course will pay dividends in the future should that therapy be needed. When we think about CLL and CAR T cell therapy in this disease, there are some differences compared to the utilization of CAR T in other diseases like B-cell non-Hodgkin lymphoma and even ALL. We are seeing slightly different profile in terms of cytokine release syndrome. We are seeing slightly more incidence of other toxicities such as HLH. And in the modern era, these things are obviously something to consider, but I would also argue that really in general, as we've been now treating patients with CAR T therapy since 2017, we've been better at actually managing toxicity in patients. We've been better at recognizing when the toxicity is happening, and then implementing therapies in many instances a little bit more aggressively and a little bit earlier, potentially mitigating some of those more serious and severe grades of toxicity. And so I think this is an area where we'll actually continue to see improvements in the toxicity profile. So when we go through just double refractory, this is a proposed definition of what double refractory CLL is. And I would caveat this with the definition of double refractory has not been standardized. This is not a definition that is necessarily being utilized in all upcoming clinical trials and something that is uniform. And so there's still some work to be done to really get a clear definition of what double refractory means. But I think this slide does a nice job of kind of walking through the different permutations which may eventually lead to a patient being double refractory. So if we start on the left of the figure here, patient that was treated with a BTK inhibitor with or without a CD20 monoclonal antibody, if that patient were to have progression on therapy, then receive treatment with venetoclax and rituximab for the Murano data in the second-line setting, and then to have progression within 2 years of concluding therapy, then that patient would be classified as double refractory. Similarly, if the patient initiated first-line therapy with a venetoclax and a CD20-based therapy, had progression and then moved on to a BTK inhibitor, had progression on that, then of course that would also be constituting double refractory. And then we look on the right side of that curve, patients had early progression after venetoclax, and then were treated with venetoclax with or without a BTK, and then had early progression within 12 months or on to therapy, that would also be classified as a double refractory patient. I should mention, when we think about refractoriness to venetoclax, that's generally a rare event while patients are receiving therapy. And if we look at the data from CLL-14, there was actually only one patient that was refractory to treatment while undergoing therapy, and then the Murano data noted 10 patients that were actually refractory on that study. And so this isn't something that's extremely common, but certainly as we're using these therapies more often in clinical practice, this is likely going to become a more prominent event. And then lastly, if we look at the right-hand side of the slide, utilizing a combo treatment in the frontline setting with a BTK inhibitor and venetoclax as more of a time-limited therapy, progression could be, a double refractory patient could be amounted to by having progression on therapy, progression within 24 months of discontinuing, or if there's any evidence of primary or secondary resistance to that therapy. And so now we'll switch gears a little bit to just looking at our original cell therapy, allogeneic stem cell transplant. And so obviously, I think we have the most data longitudinally with allotransplants in our CLL population. This study is specifically looking at the use of allotransplants in patients with 17p abnormalities. And we can see here that 3-year progression-free survival of 37%, overall survival of 44%. But of course, this is matched by a higher incidence of non-relapse mortality. And so that would certainly mean that, utilizing this type of treatment needs to be implemented in select patients, which may have a more favorable morbidity profile in terms of comorbidities where they'd be able to withstand the potential toxicities of such a therapeutic option. Next question that sort of is brought about when we're thinking about the utilization of allogeneic stem cell transplants in a population of patients that are receiving novel therapy is that a safe approach? And do we have data to substantiate the use of allotransplant in patients that previously were treated with these novel agents? And this is a study from the group at Memorial Sloan Kettering that looked at that question. And really what they were able to show is that use of prior novel agents does not appear to affect the safety of allogeneic stem cell transplants. And I would argue that, largely getting a patient into a response to permit transplant is certainly really the goal here. And as long as those patients, are able to achieve that we shouldn't see increased levels of toxicity when we move into the stem cell transplant phase of treatment. And this also, bears out in the NCCN guidelines. This is looking at the management of patients with CLL without the presence of a 17p or p53 abnormality. And we can see here, if we focus on the box on the right, in those patients that do have failure to a BTK inhibitor, along with venetoclax-based therapy and have relapsed refractory disease and require treatment, that allogeneic stem cell transplants is still a consideration. But of course, when we consider the population of patients that typically have CLL, generally older than age 70, those patients can obviously have many medical comorbidities that make allogeneic stem cell transplants risky or associated with high non-relapse mortality. And so really need to appropriately select candidates for that therapy. And that's sort of now, borne out in guidelines. So we have the EBMT, assessment of the role of transplants in CLL in the modern era. And so there's really 2 categories that they've come up with. So CLL high risk 1 would be those patients which are resistant to chemoimmunotherapy or may not have actually seen chemoimmunotherapy. They're sensitive to novel therapies like BTK and venetoclax, and they may have a 17p abnormality. So in those patients, utilization of stem cell transplant is a consideration, but really it's for highly selected patients, those patients which have low comorbidities and essentially low procedural related risk, and may not suffer from non-relapse mortality. Alternatively, if we look at those patients in CLL high risk 2, those patients are resistant to chemoimmunotherapy and additionally are now resistant to some of our novel agents, independent or agnostic of whether they harbor p53 abnormalities or not. And in this population, considering something like allogeneic stem cell transplants is a much stronger consideration, as these patients essentially have very limited therapeutic options outside of therapies that we'll discuss, including non-covalent BTKI and CAR T-cell therapy. So now we'll shift our attention to just looking at CAR T-cell therapy in CLL. And as many of us are very familiar with, CAR T-cell therapy in terms of the process is very akin to how we manufacture and use this therapy in other FDA-approved diseases. And so similar to prior instances, we are doing a steady-state apheresis in patients and collecting their peripheral blood mononuclear cells. Then those are typically shipped off to a manufacturer, in some settings manufactured on site. Furthermore, the T cells will be isolated and then eventually transduced with a retroviral or lentiviral vector, which leads to essentially the expression of this CAR construct on the surface of the CAR T cells. Following further expansion, those cells are then shipped back to the treating center, and the patients are conditioned with typically cyclophosphamide and fludarabine-based conditioning therapy, followed by the stem cell or the CAR T cell infusion rather. So now we'll talk about the CLL 004 TRANSCEND trial. This is the first multi-center clinical trial utilizing CAR T-cell therapy in CLL. This has now been presented a few different instances at various ASH congresses. So we can see here, this is I would say a relatively familiar workflow in terms of utilizing CAR T-cell therapy. Patients undergo enrollment in leukapheresis. During the time of product manufacture, there is the option of bridging therapy in order to temporize the patient's disease. Upon confirmation of the product being available and the disease being confirmed, the patients then move on to lymphodepleting chemotherapy, followed by the lysocell infusion. In this trial, patients with relapsed refractory CLL were eligible, including those that had failed or were ineligible for a BTK inhibitor. And ineligibility was defined as those that required therapeutic anticoagulation or had a history of arrhythmia. Additionally, they permitted patients with either high-risk disease or standard risk disease to enroll in the study depending on their cytogenetic risk profile. In this study, we actually noted very high overall response rates of 82%, including approximately 45% of patients that achieved a complete response. Additionally, we note very deep responses in terms of MRD, and this MRD was assessed through a flow-based approach with 10 to the minus 4 sensitivity. We can see here that approximately 75 and 65% of patients respectively had undetectable MRD in the blood and in the bone marrow. Looking a little bit further at the duration of response, which I'll focus on the left side of the figure here, we can see that among those 18 patients treated in the total group, that we see pretty impressive duration of responses, and really largely after the 12-month mark, we're not seeing a substantial drop in patients' response. This slide further delves into looking at the progression-free survival of patients treated on study. And in this study, they actually specifically broke out those patients that were previously exposed to a BTK inhibitor and failed, along with those that had failed venetoclax. And they defined venetoclax failure in this study as progression on venetoclax, failure to respond to venetoclax after 3 months in therapy, or intolerance of venetoclax. And again, we can see relatively similar progression-free survival in patients. Here, the median PFS was 13 months for the double exposed or refractory population and 18 months for the total population. This slide looks at the safety data of the CLL 004 trial. And I think really the important thing to note is, we're still seeing the principal toxicities of CAR T-cell therapy in this study, cytokine release syndrome and neurologic toxicity. But if actually we overlay the results of this study with some of the data from the TRANSCEND NHL trial, we can actually see where there are differences. We're seeing a little bit higher incidence and severity of both CRS and neurologic toxicity. In this study, they're seeing CRS incidence of about 74%. It was closer to about 40% in the BNHL studies. Neurologic toxicity, similar, about 39% in this study, close to 30% in the NHL studies. But importantly, the time to onset of CRS and the duration of that, along with neurologic toxicity, do seem to be a little bit earlier and last a little bit longer compared to what we noted in those prior trials. Again, this may be influenced a little bit by the time point at which these trials were implemented, as now we're a little bit more aggressive with some of our toxicity management. Moving forward, we do know that based on a press release, and this was at the end of January, that the TRANSCEND CLL 004 study did meet its primary endpoint of complete response rate in patients with relapsed refractory CLL, and that's when comparing that, the population of the patients which were, quote, double refractory to those patients historically and how they did after failing those therapies. And this is something that we certainly eagerly await the more mature data, which is likely going to come at upcoming Congress presentations and in manuscript form. We also know that the use of CAR T-cell therapy has been very effective, but of course this begs the question of how can we potentially improve upon this therapy? And one of the ways that was looked at was incorporating a BTK inhibitor in the treatment paradigm of CLL, CAR T therapy. And I would say a lot of this data is really born out of the experience at Penn, where they treated patients with CAR T-cell therapy that had previous BTK exposure. And in that, they actually saw some pretty promising outcomes in that population of patients that had basically received and were apheresed while on BTK inhibitor. And I think specifically here, if we look at the results of this study, which is a smaller study done at a Fred Hutch, we can see really encouraging PFS curves in terms of those that have achieved both a complete and a partial response. And then even going on to the right, if we look at undetectable MRD in the bone marrow, for those patients that are undetectable MRD, they have right now an excellent progression-free survival. This was also recapitulated in the Juno CLL trial, where they also had a separate arm looking at liso-cel in combination with ibrutinib. Again, 95% overall response rates here and very high levels of undetectable MRD with a high level of concordance between the bone marrow and the peripheral blood, close to 86%. When we think about using these cellular therapies, I think it's also important for us to understand how CAR T-cell therapy may pair with and complement something like allogeneic stem cell transplant. And I would say, in the modern era, the use of stem cell transplantation is very akin to how we use it in non-Hodgkin lymphoma. In those diseases, typically stem cell transplant is utilized in patients that fail CAR T-cell therapy and may achieve a remission with a subsequent line of therapy, and then we're using the stem cell transplant in order to consolidate that remission. And that's a similar practice pattern with how we would approach patients that had failed CAR T-cell therapy in this disease. Also, we want to look at the experience with allogeneic stem cell transplant and Richter's transformation. And this is a slide that elaborates on data from 5 different studies. But if we focus at least on the more modern studies, which are the 4 lower studies, we can see that with allogeneic stem cell transplant and Richter's, we're seeing pretty high rates of progression-free survival, close to 40 to 60% in these trials. But of course, that is matched by non-relapse mortality, which can range up to 40% in these patients. And so again, it does emphasize the fact that closely picking patients is really important to reduce potentially those risks. This slide looks at the use of CAR T-cell therapy in patients with Richter's transformation. This is a small series out of Ohio State that looked at managing patients with axi-cell in Richter transformation. And of the 8 evaluable patients with a median follow-up of 6 months, all patients responded. Unfortunately, 1 patient did eventually progress, but this does appear to be a promising option in patients with Richter's transformation. And so this brings me to my take-home points. Evidence to date would certainly suggest that CAR T-cell therapy can and should be considered for patients with high-risk disease, specifically those patients with double-refractory CLL, those patients that may harbor higher-risk features such as p53 abnormalities, complex cytogenetics, and so forth. I think it's important to plan referral for CAR T-cell therapy early in the treatment process, certainly at the initiation of second-line therapy, but potentially even in select cases at the time of diagnosis. So far, we have many clinical trials which are exploring the role of CAR T-cell therapy in CLL, and hopefully with continued time, we'll have more mature data which really substantiates the role of this therapy in that disease.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/AEQ860. This activity is supported through educational grants from AstraZeneca and Bristol Myers Squibb.